Adrenal crisis. What in the heck are we talking about? What's going on? As I sort of mentioned before, if you look through any sort of protocols, at least in the last like 5 years, they've been recently updated, including this is the Southwest Ohio protocol, but you see it in the Kentucky state protocols as well. You see something in there about adrenal crisis. And this doesn't seem to make a whole lot of sense because it's based on stuff that is not really within the EMS scope of practice, generally speaking. Like we're talking about giving hydrocortisone, which most rigs don't carry and is not really listed in an EMS scope of practice, and yet it appears in the protocol. And you might look at this and be like, all right, well, somebody got this idea into their head that like we got to do this stuff, and okay, so we'll do it. But man, this is something that we could do. Why do we need to do it? Well, here's sort of the reasons for it. Have a bit of a story to start off with. So I was working early as an attending. I was maybe like a year out of fellowship, something like that. And was seeing a lady in the emergency department, young lady, didn't have a whole lot of medical problems listed in her chart, but showed up with chest pain. And again, like 22-year-old girl, we're seeing her in the chairs area. You all remember chairs, right? Where they just had a bunch of chairs kind of sitting around, that how well that worked. Anyway, we're seeing her in there, essentially the minor area of the emergency department. And she's got chest pain, maybe a day and a half or so. It's it's worse when she lays down. It's a little bit better when she sits forward. It's not associated with shortness of breath, nausea, vomiting, fever, anything like that. Okay, no problem. We get an EKG on her, and it looks something like this. And if you're astute and you can see it, you may notice that there is diffuse ST elevation throughout essentially all the leads of the EKG, as well as some PR depression. Classic pericarditis. Troponin negative times 1, troponin negative times 2. Everything looks great on this girl. And we say, all right, you got pericarditis. Here's some aspirin, here's some ibuprofen. Go home. You'll be fine. Give it about a week or so. Everything will work out. Cool. We did that. And that was like 10 o'clock at night, 11 o'clock at night, something like that. I'm, of course, working the night shift because that's what I did at the time. Sat around all night, kind of a lazy night. About 6:50, literally as relief is coming in, there is a call from one of the nurses at the front. Hey, there's an unresponsive person in the lobby. And they bring this person back in through the front door, and I look and see, crap, it's the same girl. Shit, what did we miss? What did we not do? Immediately kind of remembered, oh yeah, she's got pericarditis. She probably has a big effusion. Wow, that happened fast, but she's probably got tamponade. And the person I happened to be relieving happened to be one of the ultrasound people with the thingies and the goop and stuff. Took a quick look at the heart, no effusion, no tamponade, nothing. When I thought back for a minute further, I thought, well, what else? She's not septic, she's not. And this girl looked like butt, by the way. She was super sick, she's hypotensive, she's unresponsive, all that stuff. Looking back at her and like, shit, you know what else was in her chart? She said she had Addison's disease or adrenal insufficiency. And when I talked to the resident about it, yeah, she actually mentioned, I have it. I haven't really been taking my medicines. Subsequently, we gave her, or the day team, gave her steroids, admitted her to the ICU, and she got better. And that's good. But it was really shocking to me, like this woman went from sitting upright and being just fine within probably 8 hours at that point, had completely decompensated. And if she'd been at home, she would have died. And that's kind of scary. You hate those. And it really had nothing to do with the fact that she had pericarditis, which she had. We were right. The problem was that she also had the adrenal insufficiency. And it works quick when you get under stress and subsequently, again, can cause you to rapidly decompensate. So long story short, that's why you got to kind of know about this stuff. What is the deal with the adrenal gland? You remember something like this, no doubt, from medical school or nursing school or medic school. You probably didn't see it if you're an EMT. I think these things are super confusing. You'll notice this thing in the center is the, well, you can't really see that little pointer. The thing in the center is the adrenal gland, and then it's got a bunch of stuff that kind of hangs off the top of it, and there's like hormones and stuff. Here's the way to kind of look through it. You have your pituitary gland, you have your adrenal gland, and you have your kidney. And these are the primary things that are going to work here. The adrenal gland releases epinephrine, got it? or adrenaline. By the way, why do they call it the adrenal? Because here's the renal, and the ad is stuck on the top of it. That's not actually a joke. That's a real thing. So it sits on top of the kidney. Initially, it was kind of thought to be probably part of the kidney itself, but is a separate organ. Anyway, and by the way, adrenaline, cool, huh? Anyway, it releases adrenaline or epinephrine, which we all know about in times of stress. In times of stress, the adrenal gland also releases cortisol. What cortisol does, it goes out to your body and essentially helps you maintain your blood glucose. If you want to like dumb it down as much as we can, it does a bunch of other stuff, does some brain stuff, but mostly for our purposes is going to help you maintain blood glucose and kind of keep your body running. That's what cortisol does. It's just, you want to say it's a stress hormone. It keeps us being able to keep up the fight. And then the third thing that the adrenal gland does is release aldosterone. And again, the adrenal gland is supposed to do is keep you safe and functioning during periods of stress. So what might happen during periods of stress? Well, your blood pressure might go down because you are hypovolemic, or you're in shock, or you're in sepsis. Adrenal gland releases aldosterone, which then goes to the kidney and tells the kidney to hold on to sodium, which means the kidney also holds on to water, and your blood pressure goes up as your volume goes up. What I didn't put on here was that it also causes you to excrete potassium. So if you have more aldosterone, you hold on to sodium and water, and you pee out potassium. If you have less aldosterone, you pee out sodium and the water, and you hold on to potassium. So aldosterone makes your blood pressure go up, if you want to think of it that way. And what controls all this? Well, it's the pituitary gland, which releases ACTH through a couple of like other processes that causes it to release ACTH, which we're not really concerned about. Long story short, adrenal releases epicortisol and aldosterone, things that make your blood pressure go up, keep your blood sugar up, and keep you functioning as a human in times of stress. And that's mediated to a large extent by ACTH, not the epi part, but anyway, I digress. How about renal failure? How about adrenal insufficiency? What happens in adrenal insufficiency? Well, there's two kinds. Primary adrenal insufficiency would be where the adrenal gland itself is just not functioning. For whatever reason, it's dead, it infarcted, it got ripped in half, something like that. What happens when you take out the adrenal gland? All those stress hormones go away, and you're no longer able to compensate for stress. Now, you can still sort of live. You may be fatigued, you may be kind of tired, but you'll kind of keep on living. Your body is really good at that, until the point where you get stressed, and then you can't mount that stress response anymore, and subsequently even small things like a little cold or what would be a mild case of pericarditis cause you to die. That's primary adrenal insufficiency. There is a secondary adrenal insufficiency that's in there as well, and that usually has to do with the signaling pathways that cause the adrenal gland to release stuff. And again, not so much epinephrine, because it's really just a CNS reflex. But secondary adrenal insufficiency, maybe it's a deficit of ACTH, maybe you have knocked out your pituitary gland because it infarcted, or because of, again, of trauma, or a tumor or something like that. For whatever reason, your adrenal gland is not getting the signal to release this stuff, and subsequently the stuff still doesn't get released, and you still can't have a stress response to stuff. Cool? Makes sense? What's the treatment for that? How do you fix a dysfunctioning... Sorry, anybody that was kind of standing there. I was off on my own tangent. What's the treatment for fixing adrenal insufficiency? Well, it's to supplement those steroids that your kidney may have released. It's to supplement all that stuff, and you do that usually with hydrocortisone. Most people that have adrenal insufficiency that we know of can take hydrocortisone tablets, and they do okay. They're able to mount their kind of stress response. When they get stressed, they have to increase the amount of steroids that they take, though. Again, most people can function just fine with a little bit of supplemental hydrocortisone, but if you develop, if you get in a car accident, if you break your arm, something that causes your body to have stress, physiologic stress, or even emotional stress, if you're in a situation, mom dies, and then something happened to your brother and you wrecked your car on the way to the funeral or something like that, that's still a fair amount of stress, and your body would try to release cortisol for that if it was functioning normally. If it can't do that, though, then you fall into that Addisonian crisis, that part where you just do not have enough stress hormones and bad stuff happens to you. You essentially just kind of shut down. So it could be something like a broken arm. In kids, it could be something as minor as a gastroenteritis. anytime a kid gets a fever, their endocrinologist, if we know that they have renal insufficiency, their gastroenterologist, or not their gastroenterologist, their endocrinologist is going to say, all right, start taking your stress dose hormone. And many families have this kind of plan sort of written up already. You know, at the top, this is sort of like the asthma kids. How do we treat stuff at home? At the top, this is a normal day. You're going to take this much hydrocortisone. When you get sick, then you're going to take, usually it's an IM shot, and they teach the family how to do this, or you're going to increase your amount of steroids. And if you're really sick, like hypotensive or your blood sugar or something like that, then you go to the hospital. And there's stuff like, even if you're going to have an elective surgery or a minor sort of thing, they'll usually have you take increased amounts of steroids. Now, the other time when this may come up that we don't think about is folks that don't have a diagnosed, adrenal insufficiency, but have a relative adrenal insufficiency. And sometimes that happens when you are given a lot of exogenous steroids. So folks that have bad asthma or bad COPD, they show up, especially folks that are not really well medically connected. You show up at the emergency department, they put you on a course of steroids. Okay, cool. You show up to another emergency department 6 days later when your steroids run out, you're short of breath again, they put you on another course of steroids, give you another inhaler, give you breathing treatments, and send you home. You show up at a third emergency department or an urgent care or something like that 5 days later when those steroids run out, still feeling short of breath. They give you a breathing treatment, some antibiotics for God knows what reason, and then give you another course of steroids. And then you take that. On day 6, 7, when those steroids run out, all of a sudden, not only are you feeling short of breath, but you feel generally weak. You have nausea and vomiting, you have bad abdominal pain, cramping, start to get confused, start to get really fatigued, may even go to the extent of having a seizure. You call EMS, they find you, and they find that you're hypoglycemic, though you're not on any sort of, blood sugar lowering agents. And you have no history of diabetes. They find you hypotensive and hypocalcemic. They probably won't find you hypocalcemic, but maybe somebody does. And maybe when you get to the hospital, maybe they find that you've got a low sodium, elevated potassium, and a low calcium. What's going on? Well, basically, because you've been supplemented with those steroids for so long, your body has stopped making them. Your body has turned off. It said, well, there's plenty of steroids here. I can downregulate, and it stops creating the endogenous steroids. So this happens to people not infrequently. They get put on exogenous steroids for a long period of time, and then when you cut them off, they get adrenal insufficiency, relative adrenal insufficiency. Now, when eventually it'll upregulate itself again, but you got to get them through that point. So the most common cause of adrenal insufficiency in the United States is actually removal of iatrogenically prescribed steroids. Interesting, huh? Anyway, what can this look like? As I sort of mentioned before, it can look like pretty much anything. You find an elderly gentleman sick in bed who is hypoglycemic and hypotensive, who is confused and who is complaining of significant abdominal pain and cramping. You may think like, well, he's got a gastroenteritis, he's got some sort of stomach insufficiency or something like that, and he is septic. That's what a lot of these people look like, and you may completely miss that he either had an Addison's disease or he's been sick for a while and depleted all his corticosteroids. This can happen to almost anybody for varying reasons. Again, sometimes it's you infarct your adrenal gland. Sometimes it's after trauma when your adrenal gland gets ripped in half or the blood supply gets cut off. Sometimes it's a signaling thing in the head. Any kind of sickly person, you should sort of think, let's make sure this person doesn't have adrenal insufficiency, because they're not going to get better until you fix that. How do you fix the adrenal insufficiency? Well, you give them steroids. And again, the faster you give them steroids, the faster they get. And reproducibly, if it is an adrenal insufficiency problem, people get better with steroids pretty much all the time. Within about 8 hours of getting the steroids, the person is significantly better. No longer shocky, no longer looking terrible. And that's why it's listed in many protocols, because there has been significant push from interest groups who are rightly concerned about folks with adrenal insufficiency and want EMS to be able to help the family give stress dose steroids when they find anybody that is ill. And that's probably a reasonable thing to do. Now, how do you do that? The come in vials, it looks a lot like the Solumedrol, and basically you're going to give this IM. If you haven't seen how to use one of these vials before, if you've only seen it depends on what the family's got, but they've probably got one of these fancy bottles. It looks something like this. You confirm, okay, all the rights. Yeah, we got it. Family hands you this vial of stuff. Push down on the top. It pops that little rubber plug down into the thingy. You take and you agitate it, and that essentially shoots water down into the lyophilized steroid, reconstitutes it. You pop this little cap off the top, and then you can give it as either an IV or an IM injection. A family a lot of times will have done this already, but you may be called to somebody who you didn't know, either you didn't know initially that they were adrenal insufficiency, and so you don't have this, or to somebody who can't tell you that they have adrenal insufficiency, or to a family that's just like, they're with grandma, and grandma doesn't know how to give the shot. What the hell do I do? This is how to do it. So you draw the thing up. You can give it as an IM shot. You can give it in the deltoid. That's fine, no problem. You can give it in the thigh. It doesn't really matter that much. By the way, IV steroids, IM steroids usually have the same bioavailability thereabouts as oral steroids. So at the doses that we give, it theoretically wouldn't matter too awful much, but we usually give this stuff IV or IM. And it doesn't, again, really matter that much which one you give. You can get a little more nauseous when you give people the hydrocortisone IV like really fast. What about other steroids? Say that we have identified a person, they have a medical alert bracelet that says, this is another person in here. This is a person with adrenal insufficiency. We know that we need to give them some steroids. We maybe even have made a medical control call to say, all right, do you want me to give this guy roids? He's pretty sick. And they say, yes. What do you have? What's our options in EMS? Well, in the emergency department, we've got a few options. We give dexamethasone, or we give prednisone, or methylprednisolone, or hydrocortisone. We can give any of the above. Hydrocortisone is the one that we like the best, and I'll show you why in just a second. But what's our option in EMS and in the field is maybe sometimes you have dexamethasone, but mostly it's probably going to be methylprednisolone, which is Solumedrol. Now, if you look at that chart, you find that hydrocortisone is actually the least potent of any of the steroids. But the thing we like about hydrocortisone and why you want to give it preferentially is that it has mineralocorticoid activity and some glucocorticoid activity. The other drugs that we give, like methylprednisolone, have more glucocorticoid activity than mineralocorticoid. Now, you may not remember what those two things mean, but basically, glucocorticoid is the blood sugar, glucose. Mineralocorticoid affects your salt function, again, the aldosterone system. So mineralocorticoid activity causes you to hold on to salt and raise your blood pressure. Glucocorticoid causes you to increase your blood sugar. So again, hydrocortisone has both of those activities, although it's the least potent. Solumedrol has more glucocorticoid than mineralocorticoid. And dexamethasone has almost exclusively glucocorticoid activity and very little mineralocorticoid activity. Okay. So basically, if you want to help blood pressure and glucose, you give hydrocortisone. Slightly less helpful is the Solumedrol, and the least helpful, although if that's all you have, that's the unimportant storm, that's fine. The dexamethasone is the least effective for blood pressure and for salt wasting and that kind of stuff. Make a little bit of sense? Maybe I'm getting too far into the weeds. Long story short, give the hydrocortisone if you can give it. If you don't have hydrocortisone, you probably have Solumedrol. Give that the way that you normally would, 125, that's fine. And if you don't have that, you could give Dex if you wanted, although it's sort of third line, not as great. Again, watch out for these guys. Awareness is probably the best thing for it. Some of these folks have medical alert bracelets. If you have a really adept, like children's EMSC kind of local response, a lot of these folks, you'll have a list of, little Jimmy over on Apple Street has Addison's disease or adrenal insufficiency, and he needs the steroids when he get it. Some family members will have that packet of stuff that says, here, use this, and they hand you the thing from the doctor that says, give the steroid. In most cases, again, check with your local protocol, but at least in Southwest Ohio and in Kentucky, that's in the protocols. You can go ahead and give that per the dosing that's listed on the vial. And there are some doses listed in the state protocols, which you can find if there's no doses. But again, usually it's going to be spelled out. The family's going to know, especially if it's a kid, this person has adrenal insufficiency. If it's adults, you can go ahead and give it to them. By the way, are you going to hurt somebody if you give them steroids? No, probably not. What if they don't have Addison's disease? It probably doesn't really matter that much. It may make your blood sugar go up a little bit. It's probably not really going to hurt anything if that is the suspected. If there's even like, man, should we give it? The answer is probably yes. And if you have any questions about it, again, look for, this is one case where like, these can be a little bit tough. Check it out, try to make a medical control call and find out what the best thing to do is. Talk about life support otherwise for these folks. You know, I've said how much time here, like 5 minutes just talking about freaking steroids when the answer is give the steroids. What other stuff do you have to do? Well, you got to do all the other life support type stuff with it. You still want to supplement their blood pressure. If their blood pressure is low, you give them fluid, just like you might. 20 per kilo bolus, 30 per kilo bolus, 40 per kilo bolus, whatever you call it, whatever you're doing locally to support their blood pressure is indicated. What about like pressors and stuff? Push dose epi is a great option, especially if you have relatively short transport times. If you're on like a mobile ICU or something like that, and you've got Levophed, that's first line for pretty much everything now. Norepinephrine drip is fine, but for all the rest of us, a little bit of push dose epinephrine to get them there if their blood pressure's in the tank and they look like butt, until you can get some fluid into them. A couple little squirts, little spritzes of epi are not a bad idea. You'll need to control their airway as best you can. Again, you can anticipate that these folks will probably get better once they get steroids involved. So if you can avoid intubating them, if it's on the fence, if you're a flight crew or something like that, and you're like, I don't know, like he seems to be protecting, but he might get worse. Once you start the steroids, he's going to start to get better. Once you start providing the life support, it's probably going to start to get better. So give these guys a chance if you can. Now, if you need to intubate them, if you need to bag them, whatever, yes, do that. But do be aware that a lot of these folks will kind of improve, and you can anticipate they'll improve once you start getting the steroids involved. And then I mentioned the epi already. Oh, by the way, blood sugar. Don't forget in these folks, again, check a blood sugar on anybody that looks at you cross-eyed, because you'll occasionally find somebody that like, well, he doesn't have diabetes. He's not on any medicines other than this, these hydrocortisone tablets. This must be adrenal insufficiency, even if it's not kind of spelled out if they're hypoglycemic. So check a blood sugar on these folks, supplement it. They likely will drop again. This may be somebody that needs, you know, the 500, the 100 ml bag of D10, and then you give them another 100 ml bag of D10, and then you're like trying to find the D50 because you run out of D10. But that is definitely out there as well. The hypoglycemia is real and tends to come back and not just stay up when you give them some supplementation. All right, to sum up real quick, folks with adrenal insufficiency get a lot better when they get steroids. And how do you know who might have adrenal insufficiency? Well, it may be tattooed on their forehead, or they may have a sign that says it, or they may have a medical alert bracelet, but you may have to do some digging. This is one of those times where like past history really makes a big deal in terms of whether or not this guy's going to do well in your care. Folks with adrenal insufficiency, when they are under stress, especially any significant stress, will die quickly without steroids within 8 hours. And if you're lucky, you're catching them early in that 8 hours. If you catch them at the end of that 8 hours, they may be literally a couple of minutes from death. So we do have to treat them aggressively, and we have to do what we can for them quickly. And if you're in an EMS, or if you're in a rural environment where you are 40 minutes from the hospital, from any hospital, then yeah, these guys need to get some steroids on board as quick as you can. If they have hydrocortisone, give them that. If you have solumedrol, that's number 2. And if you have dexamethasone, that's probably number 3. All right. That's adrenal insufficiency as fast as I can talk about it. I perseverated a little bit, and I apologize for that, but that's the basics of it.